Hi everyone, I'm Neve Belton and I'm a PhD student in UCD and a member of ML Labs. And today I'll be presenting Optimizing Knee Injury Detection with Spatial Attention and Validating Localization Ability. And I'll be presenting on behalf of Ivan Mullerathney, Adil Dalan, Ronan T. Hearn, Christina Hagos, Angus Lawler, and Kathleen Curran. And today I'm just going to go through background and motivation, the MRNet dataset, single plane model architecture, multi-plane model architecture, and explainability. And we split explainability into validating localization ability and extracting features. So firstly, we have background and motivation. So knee injuries are one of the most prevalent injuries in sporting activities. And an MRI would be considered to be the gold standard non-invasive imaging technique for knee injury detection. And we can use machine learning to develop computer-aided detection systems to automate injury detection from MRI data. And this leads to a range of different benefits, such as reduced diagnosis time and alleviating radiologist workload. The main research objectives of our work was to firstly improve the accuracy of injury detection by integrating a spatial attention block into the architecture. Secondly, performing an analysis of single plane and multi-plane architectures. Thirdly, aiding the explainability of the model by validating localization ability and by extracting features. So for our study, we use the MRNet dataset. This is an open source knee MRI dataset. It consists of 1,250 knee MRIs, and they have image level labels of being abnormal, having an ACL tear, or having a meniscus tear. Then the planes axial, coronal, and sagittal are provided for each MRI, and each plane is provided in a different MRI sequence. So next we have the single plane model architecture. So we trained a binary classifier for each plane and each task, where task refers to whether we're detecting an ACL tear, meniscus tear, or an abnormality. So we used a pre-trained multi-view ResNet 18, and a spatial attention block was inserted after the output of the last convolutional layer. Then we used a global average pooling layer, a fully connected layer followed by an element-wise maximum operation before a final fully connected layer. This is a demonstration of how the spatial attention block works. So here you can see 3 examples. Each of them is an MRI and GradCam is overlaid on them. GradCam is a visualization technique that highlights the most influential regions of an image in the model's final output. The radiologists on our team also annotated any abnormalities that can be seen on the MRI. So in example A, you can see that before attention is applied, the model is focusing on a healthy region, but after attention is applied, the model has correctly redirected its focus to an abnormality joint effusion. And in example B, you can see that before attention, the model is looking at a much wider area around the meniscus tear, while after attention, the focus is more fine-tuned. In the third example, before attention, the model is looking at the healthy femur, and after attention is applied, it stops looking at the healthy femur and focuses on the surrounding abnormalities. Then we have multi-plane model architecture. So this is where we investigated different methods of incorporating the data from all 3 planes into one network. So the data from each plane was inserted into a 2D multi-view ResNet 18 and then into a spatial attention block. And the first architecture that we looked at was called MP FuseNet. And this is where all the planes were fused directly after the spatial attention block, and they were fused along the BAT dimension. Multiplane join 2 is where the planes were fused just before the final fully connected layer. And multiplane logistic regression is where a model was trained separately for each plane, and the output of each model was input into a logistic regression model to get the final output. So then we calculated the area under the curve for each method on validation data. And as you can see here, the MP FuseNet architecture performed the best for ACL tear and meniscus tear, while multiplane logistic regression performed the best for abnormality detection. So we selected our models based on this result. And then we tested them on the test set and compared them with existing techniques. And you can see that we achieved state-of-the-art performance for ACL tear detection and abnormality detection. Next, we have explainability. And as part of explainability, we wanted to validate the localization ability of the model. And this was done by comparing GradCam to the radiologist annotations to ensure that the model was basing its decision on the site of the ACL tear. So then we needed a metric to validate the localization ability. And we had two criteria for this metric that we needed to validate the localization ability. So the first point is not over penalizing false positive regions. So GradCam can highlight area in excess of the abnormality, and this area would then be considered false positive regions. So typical segmentation metrics such as Dice coefficient and intersection over union will heavily penalize the model for this false positive region. Secondly, the metric should be standalone, meaning that it should be able to accurately communicate the model's localization ability in the absence of any comparative information. So for example, intersection over union and Dice will still be informative when comparing localization abilities across models, but by themselves, they won't offer any useful information because they over penalize false positive regions. So the first metric that we looked at was localization accuracy. And to calculate this, we first looked at the area of the GradCam mask, which is equal to the number of white pixels. Then we looked at the area of the ACL tear annotation. And then we could find the area of the overlap between the GradCam mask and the ACL tear annotation. And this means we could calculate localization accuracy as the area of the overlap over the area of the ACL tear annotation. The disadvantage of this metric is that it does not penalize false positive regions. So then we introduced penalized localization accuracy. So firstly, we got the false positive area, which is equal to the number of white pixels. And from that, we could calculate the false positive penalty, which is equal to the false positive area divided by the total number of pixels in the image. So then the penalized localization accuracy is equal to the maximum of localization accuracy minus the false positive penalty and 0. So here you can see on the left is a graph of 12 example MRI cases and their metric values for each of the different metrics. On the right, you can see two examples. The first where the MRI is overlaid with GradCam and the radiologist annotations, and you can also see the metric values for each metric. So the radiologist on our team was satisfied with the model's localization ability for both of these examples, but you can see that IOU and DICE both give these examples a very low score. And this is seen on the graph as well, that all cases were given a very low IOU and DICE score. So therefore, by themselves, these metrics are not informative of the model's localization ability. But in the graph, you can see that localization accuracy score is almost 100% for nearly all cases. But our proposed penalized localization accuracy gives a more accurate representation of the localization ability of the model, as it does penalize the false positive regions. Secondly, for explainability, we wanted to extract features. So we compared GradCam to the radiologist annotations. And the purpose of this was to investigate if the model was basing its decision on any other features that may be present in the MRI aside from the ACL tear. So we found feature detection rates of 50% of joint effusion and 75% for bone bruising. And this was verified that bone bruising is often seen in the setting of an acute ACL tear. So in conclusion, we've achieved state-of-the-art performance for ACL tear and abnormality detection. We developed a new architecture MP FuseNet that incorporates data from all planes into one network. Thirdly, we developed an objective metric, penalized localization accuracy, that validates the localization ability of the model. And fourth, we extracted explainability features that were then validated as clinically relevant. So that is everything for today, and thank you very much.